My name is Francis Levy, and I'm co-director of the Philoctetes Center. And that gentleman over there is Ed Nersessian, who's the other co-director. Welcome to Psychic Trauma, Brain, Mind, Community. I am now pleased to introduce Spencer Eth. Spencer Eth is professor and vice chairman of the Department of Psychiatry and Behavioral Sciences at New York Medical College. He serves as the medical director of behavioral health services at St. Vincent Catholic Medical Centers, whose Manhattan campus was the closest trauma hospital to Ground Zero. For the last 20 years, Dr. Eth has studied and treated children, Vietnam War veterans, and others struggling with issues of trauma and grief. Dr. Eth previously appeared at the Philoctetes Center to discuss Roger Copeland's film about 9/11, The Unrecovered. Dr. Eth will moderate this afternoon's discussion and introduce the other panelists. Thank you, Dr. Eth. Oh, yes, and one thing. Everyone's been whispering this to me. Books are for sale outside. So afterwards, you will be able to buy books related to this event. Thank you.
Okay, thank you, and it's a pleasure for me to be here today and to moderate this roundtable discussion, which will consist of a discussion amongst our panelists and then a discussion with the audience. It may be appropriate to begin this roundtable on psychic trauma with a brief introduction to the concept of psychic trauma. Now, I'm a little constrained because I know the audience is a mixed group of professionals and people who do not have training in mental health. So I'll try to, as I'm sure all the panelists, will try to be sophisticated but not obscure as we talk about these issues. Here we are in the building housing the New York Psychoanalytic Institute, so one has to start any introduction, I guess, by speaking about Sigmund Freud. In their 1893 text, Studies on Hysteria, Freud and Breuer traced the symptoms of patients with hysteria to distressing early life experiences. Freud then came to believe that these early life experiences involved a childhood seduction with actual sexual stimulation. In 1896, Freud presented this theory that the origins of neuroses could be found in childhood sexual trauma to the Viennese Society for Psychiatry and Neurology. The reaction was complete scorn, disbelief, professional rejection. The presiding chair of the lecture chided Freud that it sounds like a scientific fairy tale. By 1906, Freud had retracted his theory and instead suggested that these traumatic memories of childhood were fantasies of seduction, not actual seduction, fantasies in the context of normative or normal infantile or childhood sexuality. This reformulation of the theory of neurosis became Freud's creative masterpiece of the Oedipal fantasy, Oedipal conflict, and has been pivotal to psychoanalysis ever since. However, the rejection of the reality of childhood sexual abuse was undoubtedly an injustice to the many victims of incest and molestation, and was a factor in the long delay in acknowledging that these crimes, in fact, do occur. The modern era of psychic trauma may be considered to have begun with the care of World War I soldiers who became symptomatic after their exposure to the unprecedented scale of death and destruction in that first total war. The term shell shock was offered to describe these casualties, who were initially thought to be suffering from neurologic injury. Freud observed shell shock victims during World War I and he proposed an alternative. He thought that an unbearable situation, even in the absence of brain damage, could be pathologic. Now, this is significant because it was a formulation that contrasted with his usual emphasis on regression to forbidden childhood fantasies, because here he was accepting that the actual war situation could itself be psychologically traumatic. In his 1917 introductory lectures, Freud defined trauma as an experience that presents the mind with a stimulus too powerful to be assimilated, the result of an event that overwhelmed the stimulus barrier and was the cause of the mental disturbance. This concept was elaborated in 1926 in his work, Inhibition, Symptoms, and Anxiety, where Freud wrote that trauma may arise as a reaction of helplessness to a threat of external danger or internal anxiety. In his final work, published after his death, Moses and Monotheism, Freud conceptualized psychic trauma as being composed of two types of symptoms: positive effects or symptoms, which were the fixations to the trauma and repetition compulsions, and negative effects or symptoms, which are the defensive reactions of avoidance, inhibition, and phobia. These constructs of the positive and negative effects are remarkably analogous to the DSM-4 diagnostic criteria of re-experiencing and numbing and avoidance. Of course, large-scale traumas did not cease with the armistice of 1919. World War II, the European Holocaust, the atomic bombing of Japan, all highlighted the psychiatric effects of what's been called massive psychic trauma. Indeed, adult prisoners of war and survivors of concentration camps were often found to be suffering from severe post-traumatic syndromes that persisted or worsened over the course of years despite intensive treatment and intensive psychoanalytic treatment. The widespread public attention to the psychological damage wrought on Vietnam veterans and on women rape victims led in the 1970s to the formal establishment of a condition that is called PTSD, or post-traumatic stress disorder, a condition that is an all-encompassing category for adult victims of trauma. The impact of the horrors of World War II and the Holocaust on children was also seen to produce harmful and long-lasting effects. Child victims of maternal deprivation, separation, grief, physical abuse, and trauma of all types began to be identified and treated. Ironically, the child psychiatrist Leonard suffered a professional attack 80 years after Freud's lecture before the Viennese Society, when she, Leonard, presented her work with a group of children who had been kidnapped in their school bus in Chowchilla, California. The reaction of that audience was at first mocking and then openly hostile to the notion that these children were suffering post-traumatic symptoms. This was in the early 70s. She was accused of over-psychologizing and over-diagnosing. However, Leonard Terre was a prophetic pioneer in demonstrating that what we now call PTSD could be applied perfectly well to children and adolescents. The initial DSM-3 diagnosis of PTSD in 1980 has been accepted and revised slightly in the current DSM-4, which includes child-specific examples. New treatments including both medications and psychotherapies, have been developed, tested, and delivered to the more recent victims of trauma, the victims of 9/11, victims of torture, soldiers returning from conflict in the Middle East. And that brings us to today and our panel of experts who will address the current status of psychic trauma. I will now introduce our distinguished panel and ask them to consider the question of whether there can be a synthesis of our notions of trauma and our treatments of trauma that range from biological to psychological to behavioral as a first item for discussion today, a first topic for discussion. Okay? In alphabetical order, let me first begin with Dr. Claude Chemtob, who is a clinical psychologist and researcher specializing in trauma in children, also in adults. He is currently clinical professor of psychiatry and pediatrics at Mount Sinai School of Medicine and directs the Child and Family Resilience Program. He's conducted and published research studies focusing on children, their reactions to natural disasters and other types of traumas, and is hard at work even as we speak in these studies. On my right is Dr. Marylene Cloitre, who is director of the Institute for Trauma and Resilience and also holds the Kathy and Stephen Graham professorship, endowed professorship in child and adolescent psychiatry in the new Department of Child Psychiatry at NYU Medical School and the NYU Child Study Center. Sitting across from me is Dr. Len Shengold, who is clinical professor of psychiatry and former director of the Psychoanalytic Institute at NYU Medical School. He's the author of the very well-known classic book, Soul Murder, The Effects of Childhood Abuse and Deprivation, as well as 7 other books, the latest of which is Haunted by Parents. And finally, last but certainly not least, is Dr. Rachel Yehuda, who's professor of psychiatry at Mount Sinai and director of the Traumatic Stress Studies Division at Mount Sinai and also at the Bronx VA Medical Center. She has been an active researcher for many years in both the neurosciences and in the clinical care of persons suffering from PTSD, and is very widely published in the field. I think our panelists probably represent the best, collectively, the best minds in the area of PTSD, certainly in the city and possibly in the country as well. So, I'd like to ask Dr. Shengold to speak a little bit about the psychoanalytic view of psychic trauma.
Well, I'm going to begin with being critical of something that you said, because I disagree. Can I be heard? Because I can't tell. It's, what you said about Freud, of course, was true, that originally he thought that neurosis could be defined as seduction by the father. And when he had to change that, he felt all of his patients were repeating and by suggestion what he had said. But he never really, although he went back to his very important discovery of the power of fantasy and fantasies, he never really dismissed the actuality of seduction. Indeed, one of his case histories, the early case histories and the studies of hysteria, is someone seduced in childhood. But it was certainly minimized from that first definition of neurosis as seduction in childhood, although it's been revived by the work of Geoffrey Masson, for example, who says the same thing. And for a while there was a danger of institutes for child abuse working by hypnosis, making the suggestion, repeating what Freud did, because if you work with hypnosis, you're not going to get at what happened. You're going to get at what you're suggesting in many cases. But then there's been a reaction from that. Certainly when I was training, the first 3 patients that I had were all men, and they all had a history, so they told me, of being seduced. And when I applied to the American Psychoanalytic, I was turned down, even though I got very enthusiastic backing from my institute about my abilities and their confidence in me, because they said, he's projecting. This couldn't possibly be so. So then they told me to get a female patient, and I had a female patient who hadn't been seduced, and so I got in the next year. But it's almost 2 decades ago that I published Soul Murder, and I had talked about it before. Soul murder is a poetic term. It's not a diagnosis. I'm sorry, but I hate diagnoses, and I hate DSM-3, 4, 10, or whatever it is, because I think they're reductionistic. There are very few people who can be reduced to a diagnosis. There are a few diagnoses like paranoid personality or severe obsessive-compulsive, where there's almost a reduction to caricature of a human being. But even there are differences. And something like schizophrenia, for example. Schizophrenia is probably 10, 150 diseases. So much is a mystery there. And the difference between one schizophrenic and the other, some are capable of love, some seem incapable of love, is so great that it seems to me that although it isn't that there's no use with diagnosis, sometimes the disease is so outstanding that it takes over the whole personality. But as a psychoanalyst, we don't see that many patients. We do intense treatment. One sees how different every patient is. Every patient is a kind of new adventure, and there are always new discoveries, even though they're general things that one sees. And they're general things that one sees in relation to child abuse. And deprivation. Don't forget deprivation, because that's perhaps even more pathogenic than abuse. And they're very, very complicated difficulties that one has in diagnosis, in history taking. I had a prepared program, but I think I'm going to abandon that. But I'd just like to speak for a few minutes about what a psychoanalyst's approach is here, because to my mind, trauma is inherent to the human condition. That is, it begins at birth. Birth trauma used to be very, very fashionable syndrome again. But that's not what I mean. I mean that birth is a trauma in the sense that there is a sudden change in the environment and in whatever the internal workings of the forming mind of the fetus is, where the fetus is first the subject of pressure, pushed through this narrow passage, and suddenly appears in a world full of sensations, absolutely different from anything before. A sudden change. And much was made of this, first by Theodore Reich, And it's something that, that poets have written about. I mention poets because Lionel Trilling once said, I think, very tellingly, that Freud showed us that our mind was a poetic organ. So I'm going to go back to what I thought maybe I was supposed to talk for 10 minutes or so, to quote some poetry from what I was going to say, if I can get to it quickly. For one thing, I'd like to quote W.H. Auden, who wrote a magnificent poem on the death of Freud. And he says, he taught us to remember like the old and to be honest like children. Well, I think that's true, but of course the old don't always remember very well, and children aren't always honest. But we try to be honest, and we try to remember, and that's the best that we can do. There's a wonderful paper that's somewhat neglected now by Alvin Frank from St. Louis called The Unrememberable and the Unforgettable. And the unrememberable has to do with what goes on. I mean, there's two categories. What goes on before the mind is fully formed, because you know the birth of a human being it means the body is there, but the mind is forming. How it forms, when it forms, when the psychological birth comes, we can't exactly say. They're child observations, but there are things that are never going to be remembered from the first 3 months, the first year, and that seems to vary somewhat from child to child. So that's one aspect of the unrememberable. And the other, which is very important, is sometimes in especially overwhelming early experiences where the mind is not fully formed, and certainly the adult mind is not there. There are these overwhelming things that happen from the outside which evoke internal, what I call too muchness, overstimulation, which is the essence of trauma, I think. It can come from the outside, like what happened on September 11th, but it's what it evokes in the inside that we have to deal with. And when and how things are registered early is full of mystery, it seems to me. We know too little about that. But we can get to the way it's registered in psychoanalysis because of the reproduction from the past that occurs with emotional resonances, especially in what we call, in our jargon, the transference of the past feelings onto the analyst. And with the aid of that, so much can be revived and so much can be addressed. It doesn't tell us exactly what happened, but it does tell us what's registered as having happened. And that we can deal with and hopefully do something about.
Okay. Marylene? Surprised you're here. That's an analytic view of trauma process and the beginning notion of trauma treatment. Your work has used another paradigm.
Well, first of all, I'll describe myself as having been trained psychoanalytically first at Adelphi University, and over time, because I was interested in empirical research, moving over at the Psychiatric Institute pretty much into a cognitive behavioral frame. And I think there are lots of ways in which psychodynamic and cognitive behavioral thinking are parallel to each other. But probably the way in which I think they are most different, and the reason why I found it to be more comfortable to be in a cognitive behavioral frame, is the absence of systemic discussion about the interpersonal world in psychoanalysis. I know it's a bit of an old-fashioned idea, but basically the unit of analysis in that tradition is the individual and all of the internal pressures that come to bear against each other. And as an analytics student, I was actually very interested in the work of Sandor Ferenczi and working up through ultimately Anna Freud's work and very powerfully, ultimately, Bowlby's work, which basically says we are essentially social creatures, and that, in my view, in order to understand trauma, you really need to understand the relationship of the individual to their social context, and certainly for a child, the relationship of him or her to the primary caretaker. And in my own work, I basically embraced both types of traditions in psychoanalysis. I remember one quote that I often use just to give my students a recognition of the roots of understanding of trauma is a quote by Freud where he says, when a patient comes to us, what they do is essentially reproduce their past. Our goal as the therapeutic action of our work is to place that reenactment into the past where it belongs. So the idea being, say, shifting radically over to cognitive behavioral interventions, which is when a person is traumatized, we ask them to tell about it, and to tell about it in a coherent way with a present, with a past, with a beginning, middle, and end. And there are lots of reasons from that tradition why we do that, from a cognitive perspective, to sort of create a whole from a shattered set of pieces about what has happened and what it's meant. But I think what the two traditions share in that regard is the idea that the traumatized person lives as if the event is in the present. And our task, from whatever tradition we come from, is to try and place some distance, of the event into the past versus the present, so the person can identify their experience as different now, right, as different from in the past. I also think that when you talk about childhood abuse, and that's where most of my work is with adults and adolescents who've been abused as kids, there's not only the sort of disintegration of the self and sort of organization of memory that's impaired in adults, but also from a developmental perspective, trauma itself, and particularly the secrecy and the stigma around it, really disengages the individual from their society or community. So the adult parent, say, who is abusing their child, has a relationship with them and holds them secret, right, to whatever is going on in the outside world. And one set of rules apply in the household and a bunch of others apply in the outside world. The physical or sexual abuse itself disorganizes the child and has impact on cognitive and behavioral functioning, so that abused kids really fall off the developmental trajectory of social and emotional competencies. And there's tons of work by Dante Cicchetti and various other developmentalists showing that kids who are maltreated, including neglect and various other kinds of deprivations, do not have emotion regulation skills, do not have ability to connect effectively and empathically with their peers. They do not actually have a template of skills for reaching out and socially connecting with individuals when they're in high stress or in conflict situations, essentially because they already have a template for functioning that says basically, you don't get help when you're in distress. So the work that I do, and I think is important for everyone to consider when they work with traumatized people, is essentially the rehabilitation of the person in regards to their emotional and social competencies. So I take very much a developmental perspective into the work, as well as a sense of organizing the traumatic experience and assessing its meaning in terms of who the person feels they are and who they are in relation to the world at large. And I'll say another thing which probably everyone in this room who lived in New York around 9/11 has had some time to contemplate. They were here. But I worked for the 3 months after 9/11 in a company that lost many, many people. And our work was essentially to help the families manage those first 3 months, where basically the task was to help the companies communicate to their staff about what had happened to their loved ones. And it was a process of basically people accepting the death of their loved ones and what the next steps should be. And, we really had very little we could do there, except contain and support people as they tried to figure out what was going on. But what I was most impressed by was that the people who seemed to do the best were the people who had other people around them. And I saw literally people fall into each other's arms and really viscerally understood for the first time the power of the other to contain and support. It's really led me, since that time, probably most powerfully in my own work, to appreciate the value of the supportive other and the value of soothing and the importance of it in helping people regain capacity for functioning. And really see how the interpersonal relationship between mother and child so early in life, which is really about developing a working model about self-soothing and good relatedness to other, is really reenacted, I think, on a community level, on a social level of the individual as they relate to their community. That we're all here basically in a complementary fashion to help soothe and regulate each other in our social and emotional capacities. And I'm going to stop there.
Okay, so what I'd like to do is ask Rachel Yehuda, who's done a number of things, but significant also within her expertise is the neuroscience, how these early experiences, childhood experiences, are transduced into the brain, the seat of the mind, and then how that gets accessed later on in some way that changes behavior and that produces symptoms and that is perturbable by therapeutic interventions.
Gosh, I wanted you to give me a hard question.
Put it all together for
That one's
us.
so easy. Well, first let's make sure we're all on the same page, because when I think about trauma, the very last thing I would think about is birth trauma. Because I don't even know what that is. And even if I did, we're all born. So it kind of equalizes the playing field. We don't know what it's like to not have birth trauma. So we all start out from the same baseline. And I don't see how it's possible to even consider, to even talk about that, because how do you talk about that in relation to something else? I think that I work a lot with Holocaust survivors, and if I would suggest to them that part of the problem might have to do with the birth trauma, they might get up and slap me across the face and I would deserve it. When I think about trauma, I'm talking about the kind of things that we don't have to sort of second guess about, that we don't have to draw a map for, because they're very obvious. They're experiences that are outside the realm of what we have come to expect are normal civilized experiences. They involve abuse, interpersonal violence, things that really no one has the right to do to anyone else, that are meant to harm. Sometimes they're natural disasters that maybe aren't meant to harm, but still they produce the same kind of visceral fear response. And it's those kinds of experiences that usually someone is old enough to at least process enough to know that this is a violation, even if they can't articulate it as such, that become problematic and can affect the developing brain. Now, I cannot tell you, because I don't know exactly what happens in very, very early stages of life. The only thing that I can tell you is that I know that early attachment behavior from mother to child seems to be very important in transmitting things generationally that have to do with vulnerability or even resilience. But I can't tell you more about that except that it exists. But really from very early on, the experience of something that induces profoundly great fear changes the person. It recruits a reorganization of the brain to mobilize stress hormones that put the body on alert. This isn't necessarily a bad thing. It's probably a good thing, all things being equal. When you're afraid and you can't mobilize stress hormones, you would be worse off than if you are afraid and can mobilize them. And depending on the age you are when the trauma occurs, mobilize different kinds of defenses and resources to cope with them. Dissociation is one kind of a defense that is recruited by younger children who are abused, but there are also other kinds that occur when children grow up and when people are abused as adolescents or adults. Now, the very important thing that I do want to say is that there isn't a specific roadmap that I can describe for you called the effects of trauma, because people are very different. And that's why I'll disagree with another point. We kind of do need diagnoses, and they're helpful, because one person can respond to trauma one way, and another person can respond in another way. And I'm not talking about the fact that some people seem to not respond by showing any adverse symptoms, or highly resilient people. But if you're in practice, you've seen, let's say, somebody with a profound eating disorder that you could trace back to early childhood sexual abuse, but someone else might have an anxiety disorder, and somebody else may have a psychotic depression. And in all three cases, you may find or may not find a traumatic antecedent. So if you're an analyst, or cognitive behavior, whatever, if you're the doctor, let's put it that way, you got to deal with the syndrome that's in front of you, right? What are the
deal
symptoms?
with the human being.
The human being's symptoms, right? So if somebody has an eating disorder, right, we have a certain different treatment plan that I would suggest that if somebody is having anxiety, or if somebody is having a psychotic depression, even if we could stipulate that the same traumatic experience may be the cause of some early dysregulation that leads to some alteration in behavior. So at some point, the trauma may become less important, except that it happened, depending on what the symptom presentation is. Now, post-traumatic stress disorder, that is a disorder that's particularly amenable to working with the trauma, because sometimes in talking about the event, one can reduce some of the horrible symptoms of it. But talking about the trauma may or may not help an eating disordered patient, may or may not help a person who's developed schizophrenia, may or may not cause, may or may not, right? So I think the issue isn't so much what are the effects of trauma, because the answer to that is trauma can have multiple effects, but how do we combine the present, the symptom presentations, with the past, right? And how do we pick out the salient traumas, the things that matter, from the kind of traumas that doesn't affect this particular individual, but may have affected another individual in quite a profound way.
Claude, you're now working with very young children, and children, not only seeing the effects years later, but seeing the early reactions. What is your perspective?
Let me see. So, first of all, I just want to say that it's a real privilege to be here today and thank our hosts. I think of this as a unique New York moment. And it's good to be with several people who are friends and to meet you, Dr. Shengold. So let me speak to several aspects of that. We're coming back to the young children in a moment. Dr. Yehuda has really helped give reality to the concept that being victimized is something of the moment, that it's important. Because we tend to think of psychic trauma, because it's not necessarily visible, as not being solid and real. And she's led us in understanding that it has an ingoing and definable and persistent effect on how the brain works. And for many people, when you make something physical, that gives it a great reality. And, you know, my good colleague, Dr. Cloitre, has really, she's too modest because she's really reintroduced into contemporary cognitive behavioral things the importance of relationship. And she's someone who has shown that with abused people, you cannot treat them as if they had been in combat or raped without appreciating that at the core their pathology has to do with sustaining an injury to their capacity to be connected. Right? And I wanted to highlight these points, but first I want to start by speaking to the mythic, if you will, aspect of trauma. And Philoctetes, I learned today, was someone who was sent away to an island because his injury made everybody too uncomfortable. Until there came a moment in which the very injury was of value to the community. And this at the core is a challenge when we think about trauma, which is, do we cast away those who are injured, those who experience things that are painful, or do we in some way embrace them more assertively in order to take that wound and to turn it into a gift? So when I work with people exposed to disaster, I emphasize constantly that you are not recovered from an injury, from a disaster, from an act of terrorism, until you can find a gift in the horror. Right? So what's a gift in the horror? A gift in the horror is that you're exposed to something that is potentially damaging, in fact, realistically damaging, but somehow you are able to create something new of value that would not have existed had you not experienced that. So the mythic aspect and the heroic aspect of trauma is really about a wound that is transformed into something of value. Having put it in that context, then we ask, what's the practical way on a daily basis for those who are clinicians? How do we make sense of that? And I entirely agree that the first problem is for people to see those who are injured among us. My good colleague Rohini Lutra, who's here, and I, and with others, are working on a study, for example, in which we studied the ability of child clinicians who are presented with children coming to their clinics to identify those children who are injured, who have been sexually abused, who have been traumatized. And when we send clinicians who are, if you will, the trauma police out to talk to the same kids who the normal clinicians talk to, well, in about 157 kids that we talked to, the normal clinicians identify 3 kids with PTSD. We identify 49. Now, you say to me, as my good colleague, Dr. Yehuda said, that's because it's not really that important. They're not coming in talking about the problem. So she came over and we tested this hypothesis together. You know, she said, it's acne. These people are coming in because they got serious problems. Why do you want them to mention this stuff about sexual abuse that made no difference? And then we were all shocked as we spent a few hours and we looked at what was the presenting symptoms of these people. So one of the presenting symptoms said, child and mother come in, report child was sexually abused at 5, 2 years ago. Since then, child has been regressed, can't do well at school, has problems with mother. So you say, of course, in this case, anybody would identify that at least they would write down somewhere, because we ask them to, like, we make it easy for them. We don't even ask them to write it. We give them a checkbox. Okay? Hey, you with me? And by the way, the Joint Commission on Accreditation of Hospitals says, I'm going to judge you on your ability to pick this out. You would think they would say sexual abuse, right? And you'd think they would actually say PTSD. They don't even say sexual abuse. Now, were they in the same room?
They said adjustment disorder.
Wait, I'm not finished. You get to say that in a minute. See, these are discussions we all have been having for a long time. So they said adjustment disorder. But it's not a secret anymore. After 20 years, we now know that if you want to harm somebody's development, expose them to early victimization. Okay? Early victimization increases rates of heart attacks, increases substance abuse, increases incarceration, increases domestic violence, increases smoking. I mean, you just want to mess people up. You want to increase the rate of suicidal ideation and suicidal attempts in young women in high school? Sexually abuse them. It's not a secret anymore. You want to mess people up. There are lots of different ways. All these traumatic things lead to very bad outcomes. If somebody told you that if you inject a child with this liquid, you're going to have these bad outcomes, you'd bust down the door. Yet we're faced with a situation where people don't see it. Okay? And that's really, really problematic. And that really has an impact, I'll venture to say, on our ability to be civilized. That we allow children up the road, all around us, to be victimized without investing proportionally is really a problem. Okay? So this notion of seeing is, to me, equivalent to banishing Philoctetes to the island, because it makes us uncomfortable. Okay? So that's a mythic component. Now, what do I think happens and how do you treat it? Part of the reason I think of Marylene Cloitre as a professional sort of sister is because we really appreciate the attachment component. My approach to what is trauma started with the notion that we human beings don't recognize it, but like every animal, when we're faced with a live threat, we go into a distinctive set of information processing ways. I call it survival mode. So when we go into survival mode, we think differently. We look for the presence of threat. We vigilantly look for it. We have a bias to the negative. We identify, we have what I call a confirmation bias. If I see a little bit of threat, I believe everything else confirms it. Now, that's a very useful way to think about the world if you're in fact faced with danger. You don't want to think that the tiger that's out there, you don't want to not see it, because if you don't identify the tiger, you don't live another day to make a mistake, right? So survival mode is a very adaptive way of processing survival-related information. However, if you're not in a survival-related information, to see danger everywhere will make you treat non-dangerous moments, people who are looking at you in a slightly funny way. You're really out to get me, right? You don't smile, you're just fooling me now, right? And so you transform the way, by virtue of looking for danger, you are imagining, if you will, the danger. And there's an enormous power to being in survival mode when you're in a safe situation, because it creates real problems. And when we work with people, one of the things we do, because the problem of being in survival mode is that you lose self-monitoring. You don't know you're in survival mode. When we work with people early after a disaster, one of the things we do is teach them about, as we did together, about how people respond in a situation that provokes survival mode. From the work with disaster victims, from that early work, my group has become very interested in not only treating people after they've been injured, but how to take these lessons from early effects on people to try to prevent the injury. Okay? And we approach that in the following way. We basically think about what attitudes, skill, knowledge, and connection will prevent the adversities from becoming injurious. So, for example, with children who have juvenile diabetes, type 1 diabetes, they're faced with an adversity. You know, it's not in the biology of the mind to deal with juvenile diabetes. Most of these kids died very quickly. So how do you teach the mother and the child to stay connected, the family to stay connected in the face of such an adversity? And we recognize that what you do is identify the skills that are needed, teach the positive skills to transform that negative bias that I talked about into an optimistic one, and sustain the connection and the collaboration between child and mother. Having said all of that, I'm back to really what you wanted me to talk about, and then I'll stop. And that is, what's the impact on the relationship? And we studied children after 9/11 and brought in the mothers and children. These were preschool children. And we were fascinated about what happens between them. And we discovered that not only children were exposed directly to bodies falling, people falling, and buildings falling, but they were also exposed to the impact on their mothers. And we found that indeed, these children, if they saw what we call extremely adverse events, such as bodies falling, dead people, injured people, by themselves, that was enough to impact them. But far greater impact was the impact on their mothers. So if a mother was depressed and had PTSD, we found that those children, even 3 and 4 years later, were having substantial behavioral problems. And at the level of the relationship, you could see that their relationships had been sucked dry of pleasure and play and flexibility. The mothers were treating these children as if they were still in a survival context. So the challenge for us was to restore flexibility, the mother's ability to create a sense of safety, play, and perspective. If you will, again, to come back to this notion of imagination, a fantastic reality. The same thing that we saw in that movie about the child in the Holocaust. What was that? A Beautiful World?
It's a Beautiful Life.
A Beautiful Life. The father who created this fantastic reality to insulate his son as long as he could from the greatest horrors. When the mother's ability to create a safe world for the child was impacted, when she could not imagine that with the child began to be injured and to see an impact of that. So that's really what I wanted to say, that there is a missing context and that there's a transformational context. And as therapists, our job is to join in creating a fantastic reality for our patients from which they can begin to reimagine their lives.
Okay, so since we've all had a chance to speak, perhaps it would be a good time to open up the microphone to the audience to engage us in questions, brief comments, if you would like. Otherwise, we'll be happy to continue talking amongst ourselves, but I do want to give people a chance to engage with us. Yes, speak up or come to the microphone.
I'll try. I don't have a cat speech, so I hope it makes sense.
Can you come to the microphone?
Up.
And they can hear it downstairs.
Downstairs.
I think it'll probably make less sense at the microphone. Hello? Yeah.
What you said in very few words was by far, I think, with all respect to the other speakers, the most important part. When you said that if you talk to someone who, I'm very anxious now, obviously, went through something like the Shoah, and you mentioned to them birth trauma and such. I thought that's probably, in only one sentence or two, the most important part of. Anyway, I'm actually very anxious now.
Take a deep breath.
Well, that's actually the other thing I wanted to address. I think it's probably a little more complicated. I'm obviously interested in the topic, and I've been treating survivors of the Shoah, et cetera, et cetera. I think it's very hard to come up with something like, you just have to find the positive aspects of this. So I guess that's what I'm trying to say. And I think it's helpful if someone is very stable and very adult and verbal, and even that is questionable. I think it's hard to come up with, and this whole resilience movement that has come up over the last 5-7 years or so. I'm not sure if I can make the argument because I'm too anxious right now, but I think it's mostly a political way of dealing with horror, and it's on the clinical level. I don't think it really works that well. The other thing I wanted to say, I'm a little bit of a biologist as well, or a neuroscientist. Trauma is, of course, a big bag of many different things. One of the reasons we don't really know what it is it's many things. Two things that I think have panned out in research is trauma is, of course, the trauma of threat, and it's the trauma of loss, which is both psychologically and biologically different. And of course, since we're here, people like Panksepp have shown that a long time ago, and perhaps people like Kalin have shown that even better not that long time ago. What I'm trying to say is the biology of threat is totally different from loss, and I think that's something we can, even as psychoanalysts or psychoanalytically interested people, take into account in how we treat people, because it's actually very different. And if you think about your patients, you will find that is very it just makes intuitively sense, but there's also biology behind that. I think I should probably stop.
Can I address that?
Sure.
First. I think you've made some really important points, and I think that this tension between resilience and pathology in response to trauma has really been something, especially when you take extreme trauma like the Holocaust, when on the one hand they're survivors, and so by definition they're resilient, and on the other hand they can also be a mess, right? And the fact that they can also maybe find some good out of it doesn't necessarily make them less of a mess.
The argument of resilience is mostly they recreated families, some of them are real estate developers.
Right, that doesn't compensate, right. So having a lot of money and doing well in work and having children
No one looks at the cost.
I understand what you're saying, and I think it's important that we not think about resilience and pathology as extreme ends of a dichotomy. They're two things that coexist. And studies of the brain would support that completely. So I think what I heard Dr. Chemtob say is that you try to look for that place of resilience that you can begin to take something positive, which doesn't negate the fact that there's also a negative consequence here. I also like very much the distinction between loss and threat, and I think it has clinical implications that are really very important, because one of the things about mostly cognitive behavioral approaches, but also embedded in others, is that you try to get somebody who is thinking a certain way about the trauma, I'm unsafe still, even though something happened in the past, is that it's a cognitive distortion in a sense that needs to be reframed. And maybe you can be safe now, even if at one time you were attacked. But it's much harder to convince somebody that's experienced a loss. There is some cognitive reframing you could do around that. For example, my life is meaningless without what I've lost. You can work with that, but you've lost something that you've really lost. And so, in a sense, it is different. Not insurmountable, but I think that people that lump trauma and loss together miss an opportunity to do a more nuanced work with someone. And brain studies and biologic studies support the distinction between a neurobiology of fear and threat, which is not the same as the neurobiology of loss. And so I think that that can translate into clinical work easily.
Dr. Shengold?
I want to respond to Dr. Yehuda in relation to the birth trauma. I didn't get into my written paper. I'm not trying to say that the birth trauma is a useful concept. It's useful as a kind of metaphor. That's all.
But it's equalizing. You see.
But you see that goes back.
It's not useful. Why is it useful?
I said it's not a useful.
It's not a useful metaphor.
It's a useful metaphor for what we know and what we don't know. This is the unrememberable, and the poets can say what it's like to be born, but we'll never know what's like to be born. But what I sketched out as a metaphor has to do with the suddenness of something. The change to something overwhelming. We don't know what the child sees. That's why it's not useful. You can say that we're all born, but we all will never know what being born means to any individual child. What I would want to stress, because it makes me sound very simple-minded to say, let's think of the birth trauma as a causal thing, is how complex things are. That's what is my objection to diagnosis. Not that we shouldn't use it, but as you say, there's the mensch part and there's the non-mensch part. What we have to bring in, I think, in relation to talking about what's traumatic for any individual, and every individual is different, is there's one category in which something so overwhelming as the Holocaust, or so overwhelming as being seduced as a child, and especially seduced by a parent, where some of the parental centrality makes it all so traumatic. Those are different conditions. And in thinking in terms of our all being neurotic, at the very least, and even Freud says sections of our ego can even be psychotic. Every individual is different, and there is a period of developmental trauma in relation to what we are born with in the beginning. Think about what it means to be a child as best we can in that unrememberable first year. The child is the center of the universe. The child was part of the mother. It has to develop the feeling of a centrality of its own ego. During that time, the nursery is the universe. The first mothering person is a parental God. One goes from the Garden of Eden of the womb, where, as far as we know, and this may be an exaggeration too, everything is taken care of automatically, to a state in which the parents become all important, become godlike persons. Whether one is religious or not, the psychological basis of God is the beginning parent, the parent who can keep us away from death, who can save us, who have the promise of our living forever. And all of that narcissism, all of that grandiosity, in order to be able to conform with a reality which isn't very good, to put it politely, has to shrink. We're not called shrinks for nothing. our centrality in the universe, shrinks and shrinks and shrinks. The best of parents, the most loving parents, and being loving is not a 24-hour full-time possibility. If one is honest with oneself, and even if one thinks of oneself as capable of love and a loving person, how much of our day is taken up with narcissism, with our own interests, with keeping people away, with our defenses?
But you see, I don't like that you're attacking the idea of a diagnosis. I can concede that
I'm not attacking the idea of a diagnosis.
Not everyone gets a diagnosis right. There are committees,
What we have to deal with,
but you need a diagnosis.
We have to deal with the individual. What the psychoanalyst works with, and I think what all people who are psychic healers, or would-be psychic healers, work with, or should work with, is getting to know their patient as a human being.
Would you feel that way about your oncologist? But would you not want him to make a diagnosis?
I'm not saying
diagnosis. I want to make a little question.
I'm not saying that you shouldn't make a diagnosis. I'm saying you shouldn't reduce a human being. This is my pneumonia.
But that's a straw man, because nobody wants to reduce a person to a diagnosis. At least nobody here. Yes.
Well, I don't find that in the people that I see and teach.
I wanted to say that, in terms of the Philoctetes Center, that at least for me, and I can't speak for Ed entirely, but there were two volumes that were sort of very important to us in the genesis of the idea of the center, or to me. One was Edmund Wilson's The Wound and the Bow, in which he talks about Kipling and Dickens, who had horrendous childhoods, and the genesis of the creative personality out of this, where they could have, in one direction, gone to sociopathy and then turned to becoming artists. And then when I had read Soul Murder for the first time, in the section especially on Chekhov, with the description of the childhood. And it's just, if you take a sample population of people who have been through horrendous experiences, and I realize that, again, we fall into this question of generalities, because what is a horrendous experience? There are these externalizations, then it seems to form a whole grid of possibilities that go from the extremely horrendous external to the extremely horrendous internal and combinations thereof. But if you take a grid of people, some people go in one direction where their personality is totally destroyed and they move towards criminal behavior, all the kinds of behaviors that you delineated, the drug addiction, the developmental kind of regression and so forth. And the other is this notion of the personality, and you mentioned it also in the kind of loving universe that in Life is Beautiful, a movie that I don't totally cotton to, but still that was a brilliant point about the creation of this universe out of which the not to expel the suffering individual. But that is very much what you were talking about in your book, these two roads that come out of, like, you can take people with similarly difficult pasts that either existentially, that are a result of an existential condition that they've suffered, or an intrapsychic condition that they've suffered. And what is the reason for this? And obviously you get, again, reductionism in that, but that's one of the things that the center was founded on.
But we don't know the reason. That's a mystery. Pathogenesis is full of mystery. Obviously, if there's something so absolutely traumatic as to kill a person, that's a simple thing. But how one murders a soul, again, to use my metaphor, is a very, very difficult thing to predict in the way of what's going to come out. How is this individual going to react? It can be all pathology, or mostly pathology. It can be a mixture of health and pathology. I think what we ignore when we focus on trauma is we ignore something, again, that is a mystery. What are we born with? To get back to birth, how do we know what strengths we have? How do we know? This is what is extremely impressive to me in relation to the research that's been done with identical twins. Two twins separated at birth turn out to have the same car, the same kind of wife, wear the same kind of clothes. There is a mystery of this, what our gifts are and what our gifts aren't. There are people who are born with deprivations that make for overstimulation with even the very, very slight stress. There are other people who are strong enough to be able to bear even the loss of both parents. Okay. Children who are able to survive and help.
I loved hearing about from the trauma how helpful it is have support, large support, so that the trauma, through the support, and it can be a serious trauma, can develop into a new person, so to speak, even having all the characteristics that one had, and then even from that it changes so that one becomes a different person. If that support is there, suddenly there'll be a new support and a higher growth. And of course, each person is different, so the genetics of the people are different, the personality of the people are different, and the positivity that was talked about is so important. One wonders sometimes why some people can't use that positivity, but it's there. So we need patience for ourselves and for those others whom we love, because everybody goes through hell.
That's right. That's really the poetic way I would transform this notion of birth trauma. You know, in America, we sort of think that people will end, if we're really, really lucky, people will have immaculately clean lives their whole lives. Well fed by Gerber, and everything will be good, and even losing your virginity will come without anxiety. You know, there is no such thing as an untouched life, at least not one I'd want to live. Right? And so people are really going to be faced with suffering. And at the end, what we have to figure out by studying the people who handle suffering well, what it is that makes people recover well. And, you know, currently I'm working with couples who have lost children. One couple in Jerusalem who lost an 18-year-old to a terrorist attack. And it's a powerful thing to work with this couple, because a woman, when anything triggers it, becomes sucked into a vortex of pain, and she literally loses the ability to speak. I have never seen it quite so powerful. You say something, and she cannot. But if you say, get up and walk over and have her husband get up and touch her, she can come back. So I really support what you were saying, Dr. Cloitre, Marylene, that at the end, the connection you were speaking to is really critical, right? But this husband who wants to please her so much feels so helpless when she's in this hole that he stops reaching out unless we sustain and teach him to stay connected and give them skills to remain connected. So how do you create resilience? You create resilience by teaching people to deal with situations that otherwise overwhelm them. And hopefully you do it very early in the process, in my opinion.
I have just two remarks, sort of segueing off what just Claude said. What you said reminded me of a recent study that some of you might have read about by a young investigator named James Cohen down at the University of Virginia, who did a study looking at very well-functioning couples where the woman, the wife, was put into an fMRI scanner and subjected to the threat of getting a shock. And under these, quote, threat conditions, she had the opportunity to hold the hand of her spouse, hold the hand of a guy in a white coat, or I think no one at all.
Wow.
And when the hand holding was by the intimate partner, and it's a touch, the activation of the amygdala, which we know is present at the oncoming of a identified threat, was much reduced. So this is sort of in the brain demonstration of what happens in the brain by the soothing presence of another, just sort of reinforcing the idea of the importance of the support that comes. And I truly believe that recovery from trauma really requires the presence of others. And secondly, related to earlier remarks.
Happily married?
Oh, I'm not getting into that.
Statistical conclusion.
Not to make it too simplistic or contrasting the affect of fear, which is the defining affect around post-traumatic stress disorder, and that of loss, is that with every threat, primarily every trauma, the threat recedes, and the fear affect may reduce some, but loss is always present in every single trauma, right? Trauma is defined by an experience of loss, so that the person who experiences disaster loses a home, loses family members, the kid who's sexually abused loses innocence, and your own work indicating tremendous loss. And so I think there are ways in which we should think about trauma and loss as inextricably weaved when we work with our clients.
Well, hold on. Yes.
I'm feeling a bit traumatized and confused.
Could you please state your name? Could you state
Leslie Darrensoff. I'm a therapist and have become more and more interested in the biological and neurobiology as a way to help me understand my patients. I'm a therapist, I may have said. The core of my practice consists of Holocaust survivors, both individually and in a group with their children, and possibly soon the third generation. A couple of women from Argentina who were kidnapped and tortured, one of whom had her fetus ripped out of her while she was alive. Sorry. Etc. And a Chilean woman who experienced abrupt, violent, sudden loss of her kidnapped family under the regime, which was so horrific. So, leading up to, high-functioning neurotics who suffered birth trauma, which I think is something we're biologically geared to experience and survive. I mean, it's because we have to be born. So the idea of trauma changing one into another person and not having to find a positive outcome. I think that's what's so upsetting.
I mean, I think it's very... we have to be very careful when we work with trauma survivors in saying that you can recover from your trauma by finding some good in it. Between versus just, falling into the quagmire of despair, right? That can otherwise happen. And I think it's a challenge that we all face as trauma therapists to be very careful in that regard. And so I don't know if it's necessarily a positive outcome we're striving to work with. That the goal is to find something positive about the trauma. But I think there is something critical in the capacity to go on, and that it is a transformative process. It's not so much finding something within as things were before, but essentially I think just a will to survive and a will to transform what has happened into the capacity to go forward.
I think what one finds in relation to people who have been traumatized by their parents is a surprising resistance to change for the better. The need to hold on to the centrality that was given them by the sexual abuse or even by the beating is against the feeling that I'm going to lose my parent entirely. The suppressed anger which threatens them, which they have to bear, which is really of murderous intensity. And to be able to bring that out is very, very difficult. And sometimes, paradoxically, to be kind, to be loving, to as it were, force love upon them, terrifies them.
Yeah, I mean, I think there's...
Wait a minute. Let me just,
Can
because...
I just clarify the question?
Well, each of us needs one.
Right, but since the hour runs late...
Don't worry about the time.
Don't worry about the time. Then I won't worry about the time. But we have a number of people who would like to speak.
You can only ask questions if you walk up here.
While he gets up here, Dr. Yehuda wants to say something.
Yes, okay, briefly.
And I
You started out,
briefly.
when you came to the mic, you started about neurobiology, and you didn't finish your question. You got distracted by the intensity of your patient's traumas.
Yes.
So finish the question, because it might be very interesting.
That, by the way, was a trauma intervention.
Yes, thank you so much.
Who was?
Based on something I've noticed, which is among the Holocaust survivors, those who have, or their children, who have been adopted versus those who were in the traumatized mother's womb, have been much more anxious. And I'm wondering if, generally, would it be functional imaging, would it be blood testing that could help us as witnesses and healers put into effect the kinds of connections or words or language that can impact that particular chemistry?
Yeah.
I'd like to answer that, because I get asked this question in many different ways, but basically the reason I asked you to ask it again is because yes, the neuroscientist part of me would give you a very straight answer, which is yes, I could probably find in such people in proximity to the time of trauma of the mother and the in utero trimester changes in an enzyme called 11-beta-steroid dehydrogenase type 2, which is an enzyme that converts active cortisol into inactive cortisone. It's a placental enzyme. It begins to develop at about that time. And yes, you'd probably be able now to look at this enzyme in urine samples, but that's not really the issue. The issue is then what? Because you still have to deal with your patients, and they still have the experiences they have. And you don't need an enzyme test or a biomarker or an fMRI to validate that what has happened here is real. And I think that what we struggle with is the distraction, which I think birth trauma is, from how awful it is. You can't even get to the mic and not stop yourself from just talking about someone else's trauma. That's how horrible it is. And having a blood test to confirm it isn't going to, if it helps you, then I will tell you, yes, all of these horrendously stressful events can be confirmed, and people whose mothers were exposed while they were in utero are going to start out with that much more vulnerability that they'll have to overcome. It's true.
Okay. Yes.
Two brief comments. One is that I'm opposed to closing any doors of investigation. But I want to close this birth trauma door by saying the following, that we don't, leaving aside the original ideas about birth trauma in psychoanalysis, the fact remains that what happens during pregnancy, at the moment of delivery and after, may have some impact on propensity to anxiety, propensity to all sorts of things. So if a child is anorexic has anorexia at the time of, anoxia at the time of the birth, it may have some kind of long-term impact. So leaving that aside, my next comment is to try to see if I can get something out of Spencer Ed based on his experience. And that has to do with the fact that, yes, I understand that everybody knows it's good to have nurturing environment, whether you are traumatized or not. And if you're traumatized, you may need it even more. And it's good to have your wife hold your hands when you are in pain and your husband soothe you. I understand that. But you work with people who were very severely traumatized. And when those environmental supports are not available, what happens to them, and what is their long-term, what do you see long-term from those people? And what's the effect of the treatment?
The patients we see are the patients who are not resilient. These are the people who have been, who have suffered, who have been injured, who have been harmed by trauma. These are the people we work with and we see. And throughout, I think, all of our careers, we're impressed that the more severe the real trauma is, the more devastating the consequence. Okay, and the people I've seen, aside from those suffering from biological-based illnesses like schizophrenia, manic depressive illness, but the people I see who are in the worst shape are the people who have endured the worst life circumstances, the most severe traumas. Those are the people who are the walking wounded, and we know that. And we also know that even using the best technology, medications, psychotherapies of variety of sorts, we're not able to put Humpty Dumpty back together again. We do the best we can. And I think what we've been talking about today are some notions we have of what seems to work. And for me, what seems to work is just a couple of comments. One is I think it's an important distinction between loss, between trauma and grief. Even though many traumatic events result in the loss of a person, it is still useful to keep those two concepts separate because the psychological processes associated with them are different. They may be intertwined, but they're different, and we work with them differently with our patients. So I'm in the camp of trying to maintain that distinction. I also believe that the earlier the trauma and the more frequent the trauma occurred, the less the results of that trauma fit neatly into diagnostic categories. And remember, the DSM describes disorders, it doesn't describe people. And it's sort of a platonic ideal of what the disorder is about. People don't fit neatly into pigeonholes, and the more complex and multiple and earlier the trauma is, the less able we are to diagnose them because they just don't seem to correspond to these ideal diagnostic categories, and these are the most difficult people to treat. Having said that, I'm also been recently very impressed with people who have never recovered from 9/11. And I've been doing some work for the FDNY with firefighters. And these are extraordinarily resilient people who run into fires. Nobody I know, and certainly nobody in this room, would run into a burning building. We'd run the other way. These are guys who run into burning buildings, and I've seen so many of them who have never recovered since 9/11. And again, the take-home message to me, and they have failed multiple treatments by good people. It's reminiscent of the Vietnam vets who I attempted to treat and did research to try to develop new treatments, who also failed. And there are lots of people who start out strong, whose life trajectory is robust, who are never able to overcome severe trauma, and our efforts are pathetically inadequate. How's that for an optimistic comment? Yes.
You're going to lead me to make another point. But I worked with Claude downtown, and I did a lot of group interventions. And I'm also a trained psychoanalyst at another organization.
What's your name?
Ben Roth. And I've written 3 papers on my work downtown. And one of the first thing I pick up here today, since my dissertation is in linguistics, is that trauma is a distancing term. And it's a medical term. It's not a psychoanalytic term, and it's used constantly in this room. And one of the first things I did for the teachers I work with was deconstruct the term trauma so that they would understand it. That it has to do with pain, and Claude mentioned before how we take distance from the thing that makes us uncomfortable, which is to talk about the actual pain that the people are suffering. I also worked with fire people. I worked with an EMS man who was on the site for 3 days without sleeping. Aside from the group work. And the people in the audience keep referring to trauma, not the patient's pain at what was happening. For example, if you talk about traumatic abuse by a parent, if you rephrase that to a patient in terms of violation of trust and expectancy or violation of security, the patient responds very differently than if you use the term trauma. And we use it constantly in here. So I'd like you all to be aware that pain is a much more difficult thing to talk about in a patient and with a patient. And if you're doing it here, I see it as a distance-taking mechanism. The other thing is I saw a number of people who ran to the World Trade Center. I did interviews with all the staff at one of the evacuated high schools, and I was struck with a number of people who ran away almost immediately from someone who ran all the way to Brooklyn. Within minutes of the site, he left the high school, and other people who ran to look, and other people who ran to work in these sets. And this is a population that hasn't really been examined. The number of security people who were on site, who experienced, in quote, no anxiety, no threat, and no pain, and went and did their jobs for days afterwards. And when you would speak to them of pain and anxiety, they didn't know what I was talking about. So there is another subset of population that I think your firemen belong to, of people who are not accustomed or who, when anxious, as Claude once said, run to kill the tiger. They don't run away from the tiger. And that is a subset that doesn't come into therapy and we don't know a lot about.
You want to mention the question of training with regard to that population you just mentioned?
It didn't seem to...
Personal experience in that environment as a factor in the specifics.
I think they're drawn to it. The head of security at the high school was a woman. When I said, well, don't you get anxious? She said, no, and neither did my father.
So it's a family psychopath.
Whoa! I mean... and the firefighters that I spoke to, the guy who got on, came out of the subway at Christopher Street, commanded a post office truck and drove down to organize the ambulances at the World Trade Center. When I talked to him about was he frightened, he said, that's my job. That's what I do all day. You don't understand me. You don't understand how I'm wired.
Sorry.
Okay. Yeah. So I'd like to...
wait.
Oh, sorry.
I have to push this down quite a lot.
So get him to ask questions.
Can you hear me?
Why? I want to say something.
Yeah. Stephanie Brandt. Yes.
Hello.
Spencer was my chief resident. And we look exactly the same. Yeah. I want to say that my clinical experience with PTSD and the idea of trauma comes actually from 3 different clinical areas, and I'm wondering how much the panelists are in disagreement or have a different slant, let's say, because they're dealing with different populations and maybe different definitions. Anyway, the three areas I'm talking about are, one, as a child psychiatrist, oftentimes the presentation involves stating that there was a traumatic event up front, and often, let's say, a one-time traumatic event like 9/11 or something like that, which is publicly acknowledged, as opposed to something that's a secret. I'm not saying that's 100% true, but it's more often in that population. A second clinical area is in a forensic capacity where it's a family evaluation, and the issue of whether a child is abused or neglected or witness to family violence is much harder to disclose and verify, but so the issue of what's kept a secret, either for a public secret, is very different when you get a history. And the third area really has to do with analytic patients as adults who may or may not present the traumatic history at all, and you're working with really the personality deformation that's occurred a long time before. Also, some of the difference in those populations has to do with the amount of support and also the chronicity of some of these experiences. And in, let's say, Dr. Shengold's population, it is more likely to have had something to do with neglect as opposed to the kind of traumatic experience, that we often talk about. So my question is, how much does it have to do with the difference in the way the panelists are talking? And secondly, do they think there's a difference in PTSD presentation or the effects when we're talking about sexual abuse or family violence or something that is not easily openly acknowledged and is where there's a great deal of shame and other personal reactions that aren't as evident in a national disaster?
So secrets, who's going to deal with secrets? The analyst, of course.
I'd like to say something just to give a little clinical vignette, because I was once going to write a paper called Soul Murder Amongst the Rich. And I could write it, but since I see mostly people in the field now, I don't think I'm ever going to be able to publish it. But I would like to bring up just a very short clinical example of soul murder that doesn't specifically involve sexual abuse or being beaten, but simply was psychologically a traumatic event, that is, an overwhelming event. This was a man whose two parents had a big horse farm. That was their hobby. And they took great care of the horses, but not of their children. There was a kind of sexual abuse factor here, because the only person who really cared about him, and not being cared about, of course, is a primal kind of pain. I won't use trauma. Was a servant. The servant there was some sexual play. But the overwhelming thing was that, illustrated by this anecdote, every Christmas the tree would be magnificently covered with ornaments. There would be presents all over the place. And every Christmas, after all the presents were opened, they were then packed up to be given to the poor children. Every year this poor kid felt, no, they won't do it to me this year. They won't do it to me this year. But they did it again and again and again and again. This man had no capacity for joy whatsoever, which is one definition of soul murder. Now, it isn't, this is a different category of what happens between parent and child. But between the parent and the child, so much goes on, and so much is so central. And I think that's true in relation to all of our presentations here.
Right. And what you're describing is an empathic failure, but I don't think most of the rest of us would call that a trauma.
Right.
But secrets. Anybody want to deal with a secret trauma versus a public trauma and the implications of that?
I will be very short. Oh, I'm sorry.
Well,
I'll be very short.
Okay.
I think that we don't read minds. If we don't ask, they don't tell. If you don't know, you should ask. Asked and answered. If they say no...
But how do you know you're going to get the truth?
If they say no, it doesn't mean that it didn't happen. If they say yes, it doesn't mean that it did happen, but you're starting from someplace, and you're starting from the ability to have a dialogue.
Absolutely. Even when they tell you, most clinicians, we've just demonstrated, don't hear. I mean,
even when they tell you, you're gonna. Some people will ignore it.
It's not the whole population, is all I'm saying. Of people who are, if you're asking an history and the patient says yes or no, you're eliminating the people who say no in a certain sample.
You're just noting it down. You might come back to it. They may say something that contradicts that later.
I don't know.
But you ask them why they're there. I mean, don't we start by asking somebody, what is the problem? How can I help you?
In practical terms, because you're really saying, okay, so how do you get practical about this, right? And in practical terms, we now know that if you've been in combat, you probably should ask about what's happened to you in combat. You know, that most clinicians should ask about the traumas that somebody's experienced, if only because it may not be a truly traumatic event, but I tell you what, challenging adversities will always teach us about the adaptive style and capacity and functioning of the person. You see, so, but most people neither ask nor hear. And that's really the first problem.
That's true.
You see what I mean?
But do you make that assumption about me?
Sorry, just one second.
I'm afraid you do.
There are some situations where children will not disclose.
And that's okay, because you can ask later. You don't have to ask only once. I've had patients where I later found out they'd been raped, and I'm supposed to be a trauma guy. And when I found out, it all fell into place. Why she couldn't set up a relationship that worked. Right? There's something about being exposed to, as Ben said, people's pain directly that's so discomforting, right? And I just need to say something to people who challenge this notion of resilience as a sort of simple-minded, positive view of the world. You know, when you talk to somebody who's been through the Holocaust or lost a child, let me say lost a child to terrorism, you know, what idiot thinks that you're going to tell them their life is not changed? I mean, you know, who in the world thinks you're going to feed them sugar? Right? But if it's destroyed their ability to remain connected, and if it's part of the nature of being traumatized, that your ability to be connected is harmed, and worse, that the ability of others to connect to you because you're in pain is injured, then the positive view of this is, you know what? If I learn something about it, I can teach you so you're not injured forever. But you will not. You will be a twisted tree. You will not be a shooting up tree. You will be twisted. You know, it's
to put together everything that's been said before. No, it's perfect. In relation to your question, is that by introducing the question, have you ever been raped? Have you ever been sexually abused? Have you ever committed a crime? It introduces that as a possibility in the dialogue, and it allows possible recognition of it in that world. And I think what Len was saying when he told the story about the Christmas tree is that it is a terrible injury to not be recognized.
That's right.
And that's what the story of the presents are. That this is not for you. This is not about you. I don't see you for who you are. So a person may not be ready to acknowledge who they are, but you've said, I'm here to listen if you care to tell at some point.
But you have to take into account the resistance of some patients.
But my question really had to do with, is once disclosed, if a child has grown up without it being disclosed and it's a source of shame and whatever, age 30, you see at some point it's disclosed. Is there a difference in the outcome for people who are traumatized, for whom it was kept a secret for many years, versus somebody where there was an open acknowledgement?
Well, I would say yes.
I mean, common sense would say so.
That there's no empirical data. There is on secrets?
Yes, there is.
Okay.
We know that shame is one of the strongest predictor of poor outcome in psychotherapy treatment among trauma survivors.
Shame over secrets?
No, shame related to their trauma. And that's Chris Bruin's work.
Right. And secrets could be a source of shame.
But part of the dimension that is completely confounded is that it's usually something that happens when the person is much younger and much more vulnerable, right? So that the developmental impact on the capacity to connect is the part of the challenge that has to be addressed in terms of treatment. And it's one of the things that, Marylene is really understood, that the very shame will make you shrink from the ability to join with a therapist, and that failure to form an effective treatment alliance, for one, will make you leave the therapist, right? In the most obvious, you don't have to invent rocket science. The person won't go back, right? And so part of what she's been teaching us about is how to modify technique to address the therapeutic alliance in the context of disclosing secrets that happened to you as injuries as a young person.
Okay. Yes.
Three other people waiting.
Yes.
So.
I'm done. I'm finished.
So one of the my name is Jonathan Lebov. One of the themes I think earlier in the discussion was baselines. What we're all bringing to the table, what we're all born with, what's universal. And when we speak about baselines, you also speak about evolution and what evolution has prepared us for. Evolution prepares us for predictable events in our environment, and certainly psychic trauma like losing loved ones or real conflicts. We have fight or flight mechanisms, defensive mechanisms, and I thought one of the interesting things in the description of the talk was right in the first sentence is it mentions natural and technological trauma, and like for example 9/11 to me would seem an example of a technological trauma, something that was not, or the Holocaust, the genocidal events that were not happening on on the savannah. And perhaps even sexual abuse too. I don't know. I'm naive as to the anthropological history of sexual abuse and how far that goes back in human culture, whether that's a natural or technological trauma, if it's a more modern construction. And I suppose my question is, to what degree are we prepared at a very general level for trauma in our lives, or if we're better prepared for, we have evolved adaptive mechanisms for certain types of events like losing loved ones and things like that were happening long ago in human culture, as opposed to less natural events such as 9/11, whether natural and technological in the description was meant to be, whether that was part and parcel of trauma or whether or not those are two totally separate concepts.
So what I hear you asking is, fight and flight is a natural response, an evolutionarily based response to danger in the world. Fear is there, can PTSD be understood, or can abnormal reactions be understood as evolution gone awry, and are we adapting properly to the new threats in our environment? That's a Rachel question.
Oh, thanks. I think trauma's been around for a really long time. There are biblical accounts of sexual abuse, if you consider that a long time. I think that when we talk about being prepared, the fact that we mobilize stress hormones and we recruit many different physiologic functions to be able to do fight or flight is one type of preparation, but it doesn't necessarily prevent psychic pain. And so, the good news is you're alive, and the bad news is you have psychic pain, right? So that's what we do. Isn't that great? So I think we have to explain that survival isn't a dichotomy, that at least you're not dead. Okay, that'll be $150. You know, there's more to it than that.
Okay, thank you.
The talk about trauma and childbirth reminded me that lots of societies
obviously at the VA
have sort of officially sanctioned trauma. The most common one, at least in this country, is male circumcision. And I'm wondering, how does these, and this is common amongst many, many cultures, these kinds of body mutilation or trauma to children or sometimes in adolescents, and how do these traumas relate to the type of traumas that you're talking about? And do they also have psychic harm?
Well, I've never had a patient come in and complain about the trauma of their circumcision, so I don't know.
Right. In other cultures, it's done older. Yes, initiation.
Same issue. Maybe
right.
one is sanctioned and one is...
Yes, initiation rites can be traumatic. And are they adaptive in certain cultures, and what is the role of that, would be an excellent roundtable, which would have to involve cultural anthropologists and people with other areas of expertise. How's that for dodging
See, I
the question?
think that question minimizes real trauma. The kind of trauma that you came up to the microphone and choked out, you know, is not the same
as having a circumcision at age 14? I don't know about that.
In 14?
At 14?
If you complain about it, and if you're traumatized by it, okay, but still, if you chose it and it was if it was a ritual rite, even then, if it's something that you chose to take upon yourself, it's about how your brain perceives what is happening to you.
But
and if your brain, if somebody tells you it's barbaric,
perceive it differently.
If you believe it to be barbaric and you're traumatized by it because someone's doing it against your will, it's assault. But if you're taking upon yourself as a religious rite, then it means something different, even though it's the same act. Exactly. But I think that when we talk about potential trauma, quote unquote, like this, I think we minimize the kind of traumas that are too hard for us to even know how to deal with.
That's right. But isn't there a spectrum of trauma that we've been dealing with from the beginning, which is there are extreme, overt trauma?
They're not, all traumas are not alike.
No, they're not.
Right.
And not all pain is traumatic.
Trauma, right? Or, I mean, because to me, I think there are people in cultures where it is accepted to circumcise women at the age of 14. Right. It is traumatic for them, and they might be participating in it, but it's not willfully, and they don't know that it's potentially damaging because they're in a cultural reference that says that it's okay.
But let's start with all the traumas that we can agree that someone had absolutely no right to do to you, and not go into culturally sensitive areas.
Why not? Why not?
Because it's a way of avoiding
right, thank you.
The high frequency at-home traumas. You know, I mean,
that's why only 3 therapists wrote PTSD in Claude's study.
Okay. Anyway,
that's why.
Not to minimize it, but to sort of say that that's I think would be more suitable for a different kind of roundtable. Yes.
Hi. My name is Michael Friedland, and I am not a psychologist or of any kind, so most of my experience with people like you is on the couch rather than on the chair. I guess I'm curious, you all have different disciplines within psychology, and for me, it was interesting to hear the comment about linguistics, because I actually find that a lot of the conversation is part of the traumatic experience. When I am listening to someone tell a story about having a fetus ripped from a woman's body and seeing her react to it, I feel the trauma of it, and clearly she does too. And so when you talk at the beginning about recontextualizing something that happened that was traumatic in someone's past, or when you speak of finding the gift in it, it's difficult to understand how effective that can really be when amongst the professionals, even we have a hard time putting it in the past. She was recounting a story that didn't even happen to her. It happened to someone else in the past, and yet it was evidently traumatic enough then to her that it's even being relived now. So it's difficult for me as a layperson to parse out how to go about being effective at this when even amongst the professionals, the trauma is not actually the thing that occurred; it's the reaction to the thing that occurred. So,
absolutely.
Well, I don't know. That seems to me because I've been, my idea of a traumatic experience until I was 19 was getting into a shoving match at Hebrew school with my friend John, who invited me here. Well, I'll say this because this is why I bring it up. I had a traumatic experience on the streets of London where a bunch of guys basically mugged me and my friends, and the next day at lunch I'm totally traumatized, and one of my friends who has the same background, who also got into the same shoving matches at Hebrew school about yarmulkes and stuff like that, he's fine, and he thought it was hilarious that we got mugged in the street and that we happened to come out of it okay, whereas I ran every permutation of what could have gone wrong. And I think that there's an idea, I don't know if anyone has ever read anything about memes, like Richard Dawkins' meme, the idea of ideas being just like genes and how they spread virulently from one person to another, or positively. But there's a part of the conversation that I find is just the spreading of ideas from one person to the next, and they find these ideas are fertile in someone's mind and not fertile in another person's mind.
And what you're addressing is very important and very familiar to all the therapists in the room. Right. Part of what you're talking about is the phenomenon of vicarious traumatization, where we respond to other people's traumas. And it was exceedingly well documented on 9/11 when people would watch television hours later and develop traumatic symptoms, okay? The other piece of that is what we call countertransference, which is sometimes doing therapeutic work resonates with our own personal histories, perhaps even our unconscious conflicts, and we respond to that peculiar to ourselves. And both of these phenomena have been, looked at, written about, and would be a very important part if this was a series rather than a single session today.
But the short answer is supervision, and that's why therapists come together like this on their spare time. That's why even therapists see therapists for exactly this reason, because it is an ongoing thing. You don't want to say, you'll get used to it, and that would maybe be true, but you're happy to have the empathy on the one hand. It does bring up conflicts on the other hand. There are ways to deal with it on the third hand if you have a third hand. But it is something that just since you're not a therapist, there is a systems-wide approach to this, and being able to understand that your patient's events impact you is really the first step.
Okay, we need to have two last questions with the two last people who are standing up, and then we're going to conclude.
Can I just mention, though, I think that it's a wonderful thing that a professional can disclose difficult case material and we respond accordingly, because I think, the gift of empathy is wonderful. It's what really makes the therapy work that we do effective, managed within our own capacity for emotion regulation and problem solving and metacognition,
Hi, I'm Sandu Brashadsky, and at Frank's urging, I got up. I have been in a tremendous traumatic experience. I had a high-speed rollover accident that rolled over 6 times and survived it. Was treated by a trauma specialist, and I thought someone else would get up who had a first-hand experience, and had all the classic things, flashbacks, tremendous guilt. My girlfriend was with me. She was not as hurt as I was, and I followed the rules of the doctors that told me. They told me what to do and how to act and how to face it, and that really was it. I guess what I learned the most was one of the things I used to say is, don't worry about it, you're with me. And I found that I could no longer ever say that about anything ever in my life. I think the hardest thing that there was for me to get over personally was I felt guilty for putting her in the situation that she was in. I was driving, even though I was forced off the road, right? She was with me and she counted on me. She doesn't drive, which is one of the things. But I guess the only recurring thing that has to go on in my life, and we're still together, and is that I have to prepare myself for any travel with her and us together. And we do that. Renting a car, we have to walk around it, we have to sit in it for a while, we have to make sure that we're ready to do it, and we do it. And it takes a little bit of work to overcome it. About the only thing...
How long ago was the accident?
4 years ago. And the other recurring thing with me is I have some anger because I was a marathon runner and I hurt my back and I cannot run anymore because of this accident. But the thing that remains to me on a mental level is that I have a sensitivity to sound. The sound that occurred while this thing was going over and over and over, right, was just tremendous. And when I'm walking down the street sometimes, just like going to get a sandwich or that, when I hear this sound in the street that kind of like all of a sudden resonates in my ear, it's frightening to me. You know, it doesn't happen all the time, but it is frightening.
Thank you. Last question.
Very quickly, I'm not even sure it's a question, but I do want to make, one comment about, the shame and the guilt that leads to the need to create secrets, and that in my experience as a therapist, there is something that hasn't been talked about, which is the patient's need to have not only questions and an understanding of the lack of fear, so that neither of you have to go to the island, but as well an assessment of whether you're deserving to actually witness their pain. It's something that is so not connected to humanity often that I think it's very important for them to be cautious. That's all. And
Thank you, and that's a suitable last comment, and I want to thank our panelists and our audience.